Good morning and welcome. I'd like to introduce you today to Hester. She recently turned 40, and just a brief history, she had, I think it was some botulinum toxin in the frown and forehead area about 2 years ago, and about a month ago she had some fractional treatment. So besides that, she hasn't had really any other aesthetic treatments. When I asked her what really concerns her, she kind of shook her head at me and said, no, nothing really, but the one thing that I don't like is, and she put her head a little bit down and she pointed to this area and she literally pulled and she said, I don't like this laxity. Now, so, I'm sure all of us have had patients come into our practices and basically say, doc, if I can just do just this little bit, I'll be happy. So it's a fairly common request with most of our patients. And I'm just going to go through my approach and how I treat and improve the actual jawline and maximize the degree of lift of that jowl area. We basically only have three places that we can place or put filler down to create lift and support of this jowl area. The first is the outer cheek area or the arch of the zygomatic bone. The second is the back of the mandible, where by placing filler we can create lifts more laterally. And the third and the final spot, if the patient has that pathology, is on the front of the chin, because those are our three drawing vectors. The rest of the areas that we place filler to improve the jawline, like any indents below the lip, as well as the indent between the prejowl sulcus and the chin, those are not really supportive fillers. Those are more to improve an indent or to replace lost volume. Okay, then the question arises, well, when we have all these areas that require treatment, where do we choose needle and where do we choose cannula? And that answer I normally base on our vasculature. We all are aware of the facial artery. As it enters in front of the masseteric muscle, it becomes quite tortuous towards the angle of the nose, where it travels up to become the angular artery, as well as the dorsal nasal artery. The facial artery gives off a superior but also an inferior labial artery, and in this area, which you can see is close to the areas that we will be injecting, we also have the mental artery. So when it comes to treating this area, my preference is to use cannula, especially when I'm working in the region with such a high vascularity. Also, similarly, when I'm treating this area along the actual jawline, just between the jowl, the pre-sulcus area and the chin, my preference is also to use because of other ascending arteries. So to recap, or in summary, I'm going to be using needle on the back of the jaw as well on the zygomatic arch, and we're going to be using cannula for the other areas. Okay, thanks, Hester. You can relax back for us. The first filler that I'm going to be using is Juvederm Voluma. Why I like the Juvederm Voluma for the cheek area, the obvious one is that its on-label indication is the cheek, and it also has quite a nice G' or lifting effect, and which is what we want to achieve. Bart showed us earlier on a great demonstration turn a little bit away, a great demonstration of sterility or an aseptic technique. And it is so important, irrespective of whether we're doing dermal fillers or if we are doing threading, it is highly important that we create as much sterility by using alcohol or chlorhexidine in the area. When injecting this zygomatic arch to maximize the lift and support, I like to draw the skin back as much as possible, as I do believe that provides almost like a ledge where the filler provides a maximum support. It is important that we don't draw the needle back and we follow. We want the filler to be placed in that area on the zygomatic arch. I tap, I touch the periosteum. We can now let go of that actual pressure because we created that just to aspirate. We'll make sure that we get to 7 and that there's no blood that comes back. And slowly injecting, here I'm going to do about 0.15 mils. Obviously, with the advent of ultrasound technology, we have the ability to safe map prior to we inject. But yeah, one should, without ultrasound, one should actually generally aspirate with each injection point. I'm going to do a second one right next to that. Again, I'm going to draw back. I tap on the skin. The tapping just distracts the nerve. Again, we're going to aspirate. We generally hold that for about 7 seconds. And here I'm only going to deposit about 0.1 mil. We can see that where the bulges of the filler is, I immediately mold and I put a bit of gentle traction towards the outer lateral aspect of the cheek. And Bart said earlier on that he doesn't ask his patients to help him, that he doesn't need assistance. I always ask my patients for assistance. So Hester, just give me a right hand, and or left, it doesn't matter, and just put quite firm pressure there. And this is important because it helps minimize the degree of bruising afterwards, but it also gives me a chance to change over to the next filler. And here I'm going to be using Juvederm Volux, again, mostly because its on-label indication is the actual jaw as well as the chin. And then the second reason is because it has a very high G prime and has a really nice lifting effect, which is what we want to achieve with that jawline. Let me take this away. Thank you, Esther. Put that away. So turn a little bit more. And now our goal or aim is to place on the very posterior aspects of the mandible. These two lines represent the actual masseter muscle. So we want to place just behind the masseter muscle. Here I also find it very important to draw the skin back to maximize the degree of lift and support that we can achieve. So I place it right on the posterior border of the actual mandible, draw the skin back firmly. My thumb represents the inferior aspect of the mandible, and I want to place just above my thumb. And here I'm going to be placing 0.5 mils. So basically half of the filler will be deposited. Draw back and immediately put a little bit of moulding and support. And again, we can ask our patient to put a little bit of pressure there. I'll show you how much. 9 minutes, thank you. And this gives me a chance to get my cannula and next fillers ready. Yes, please.
Volux.
Volux. Now, Hester, we never put any topical anesthetic or anything like that. This is the first time that you've had dermal fillers. How would you rate the pain or discomfort on a scale of 0? I'll take this, thank you. 0 to 10, with 0 being no pain and 10 being the worst pain and manageable. No, okay, no pain. That's amazing, actually. This is the best model to have at a congress. So just before I lie down, let's sit you straight up, face the camera, and then let's just see the difference, if there is any, between the two sides. Lean the head a bit forward, sit down, let's have a look. So one can see quite a significant difference already, where that jowl is a lot more obvious versus on that side. And then with the rest of the treatments, we'll improve that area even more. For that, I'm going to drop you down. I think the camera can follow. That's fine. So we're going to be, where's the needle?
Oh, there it is.
We're going to be using a cannula for this area. So I'm just going to make a small entry point. Turn your head a little bit away from me. I'm starting with the, can you see? Is that fine? I'm starting with the indent below the lips and between the chin. because we want to create a bit of a smoother support and reduce that indent. Must remember that the facial artery is just lateral to our entry point here. Needle going in. So that tapping is just really to make it as comfortable as possible for the patient. It basically distracts the nerve. And hopefully I don't struggle as much as Tracy. I'm much older than her and my eyesight is not as good. So let's see how it goes. So we place it into that entry point. And just, if you can pass me a little pointer, that's fine. Just a tip. When we look and we see this indent, our natural tendency to treat would be right down the middle and let's place filler. Don't do that. Actually angle the cannula and treat a little bit inferiorly, draw it back, and superiorly to that central line. And carry on doing that until you get to the middle section. The results are a lot better than just try to place it in the very middle. So, sorry, Hester, this is or can be a sensitive area, especially when we get over here. Now, do warn the patients so that they are aware. So you can see I'm at a slight angle. I'm not 100% in the middle. And then we withdraw as we deposit. And I get, sorry, my fault. Again, I go slightly superiorly. I deposit. Again, slightly inferiorly. And I carry on doing that and slowly placing the cannula closer and closer to the very central part of the submental area where we want to maximize that degree and support of that indent. Now I'm going to move towards the chin. And here we want to place just about 0.1 to 0.2 mils, depending on how much forward projection we want to create. I can see the tip of the cannula. I do sometimes aspirate here just to be on the safe side. It's quite a vascular area, and I deposit 0.1 mil, move it around a little bit, slightly lower down. Again, a slight degree of aspiration, and I deposit another 0.1 mil. Turn straight. And the very last area I'm going to treat is basically the indent between the actual the prejowl sulcus or the jowl and the chin. And for that, we're going to be using a cannula again. I'm going to make a small opening, turn a little bit this way. That should be up. Needle going in. That one always tends to bleed a little bit. And again, we're going to place the cannula through that opening. And this will be just above bone. And I can see the end of the cannula right there. We'll feel it. And then as I withdraw, we're depositing filler. This is all still the Volux. And this is just to give as much strength and support to that indented area. What is important is to immediately mold. So we're almost trying to create this like rectangular kind of placement of filler. I stretch the skin to ensure that it looks uniform, that there's no lumping. Just need a facial wipe. A normal wipe. We are done. I just want to wipe all the pen marks off, and then we can sit Hester up and we can show a comparison between the two sides. Hester, how was the last section? Was it a little bit more sensitive than before?
Not a bit.
And did it help that I warned you that it was going to be sensitive, or do you prefer to hear those kind of things? Okay. How much? 40 seconds. Wow. Okay. Turn it with that way.
And the other one.
It should be fine. It's just to show that it doesn't have to be all of. Okay, so you can sit up for us again. Thank you. Okay, so again, we can see the difference between the two sides. It actually starts up at the lateral canthus of the eye, all the way down, including the difference between the nasolabial folds, the corner of the mouth, and the depth of the indent. And now let's check that the jowl area. Turn a little bit forward. We can see a significant difference when the downward pressure actually produces traction on that actual jowl, where it looks a lot straighter and more smooth versus on the actual jawline. Thank you, everyone.
Thank you, Dr. Alek.